calcium balance. As this diagram you can see very clearly, calcium availability in the small intestine, dietary calcium to calcium ion under the action of calcitriol, PTH and prolactin having a positive effect on it. Some calcium is secreted into the small intestine, the ECF. Now, the ECF into the bone, calcium is needed to convert that into calcium. Long-term storage in the bone. Now, on the other side, in the kidney, the waste PTH acts to maintain extracellular calcium at the expense of the bone. Passive filtration of calcium ion, the calcium ion in the kidney tubules, and PTH has a positive effect, calcitonin inhibiting effect. Via the electrochemical gradient, calcium ion moves from the ECF into the cells, and through active transport, there's need for free calcium to move back into the ECF. And the biological response from the cells, long-term storage in the bone, availability of small intestine, and the waste at the kidney. Regulation of PTH release. PTH is not under hypothalamic control, but responds directly to plasma calcium levels. Decrease in plasma calcium ions will have a positive effect on the PTH. As the plasma calcium ions increases, this has an inhibiting effect on PTH. Actions of PTH increases osteoclast activity in the bone, which causes an increase in serum calcium. It also increases calcium reabsorption in the kidney by upregulating the activity of all alpha hydroxylase, and it increases calcitriol. Physiological response to hypocalcemia. Decrease in the plasma calcium causes an increase in the PTH secretion, resulting in the mobilization of bone calcium and phosphate, increased renal phosphate, increased excretion and Ca2 plus retention, and increased vitamin D3 synthesis. The outcome is a rise in plasma calcium ion levels and maintenance of normal phosphate levels. Decrease in plasma calcium and increase in PTH receptor. Increase in breakdown of bone. Increase in formation of calcitriol, increase in calcium absorption. Calcium absorption increases, increase in plasma calcium. Physiological response to hypercalcemia. Since in diagrams there's an increase in the plasma calcium because there's a decrease in the PTH secretion. Decrease in breakdown of bone, increase in formation of bone, decrease in formation of calcitriol, and decrease in Ca2 plus absorption. Less Ca2 plus uptake from gut. All causes a decrease in plasma calcium. Increase in plasma calcium causes decreased PTH secretion, resulting in reduced mobilization of bone by osteoclast and increased formation by osteoblast. Decreased renal calcium absorption and reduced calcitriol synthesis. The outcome is a reduction in plasma calcium levels. Calcium sensing receptor. The calcium sensing receptor is a G-protein coupled receptor. It's located in chief cells of the parathyroid gland and also in the parafollicular cells, which release calcitonin. Absorption of calcium in the human intestine is via both transcellular, passing through the cell, and via paracellular transport. Transcellular transport is dominant in the duodenum and transcellular transport is primarily regulated by calcitriol. Calcitriol increases the amount of calcium passing via CA2, so known as TRPV6 channels. Calcium binds with calmodulin so that it is not available for the entire site just passing through. Within the microvillus, the calcium calmodulin complex binds to a protein transporter called brushed-button myosin 1 and moves out of the microvilli. The calcium is then bound to calbindin and is transported across the basolateral membrane. Calcium is actively pumped out of the cell by the C8 against the gradient. Calcitriol may increase calcium transport through the enterocytes by increasing the amount of calcium leaving the microvillus. These effects are seen with denials of calcitriol treatment and are non-genomic actions of vitamin D. Physiological response to hypocalcemia. Decreased plasma calcium causes increased PTH, resulting in mobilization of bone, Ca2+, and phosphate, increased renal phosphate excretion, and Ca2+ retention. Outcome is a rise in plasma calcium. Maintenance of normal phosphate levels. Decrease plasma renin, increase PTH. Breakdown of bone, increase in formation of calcitriol, increase in calcium absorption, all cause an increase in calcium absorption and increase in plasma Ca2+. Physiological response to hypercalcemia. An increase in plasma calcium causes decreased PTH, resulting in reduced mobilization of bone by osteoclast and increased formation by osteoblast, decreased renal Ca2+, absorption and reduced calcitriol synthesis. Outcomes a reduction in plasma calcium levels, increase in plasma calcium, decrease in PTH secretion, decrease in the breakdown of bones, decrease in formation of calcitriol, decrease in calcium absorption, and decrease in plasma calcium ions. Calcitonin is a peptide hormone secreted by the parafollicular or C cells of the thyroid gland, synthesized as the prepulmonary release in response to high plasma calcium. Actions of calcitonin. The actions of calcitonin generally oppose those of PTH. Calcitonin acts on bone osteoclasts to reduce bone resorption. Calcitonin acts by increased CMB concentrations to inhibit osteoclast motility and cell shape and inactivates them. The major effect of calcitonin administration is a rapid fall in Ca2+ caused by inhibition of bone resorption. Calcitonin. Role of calcitonin is normal calcium ion control is not understood. Chronic excess of calcitonin does not produce hypercalcemia. Removal of parafollicular cells does not cause hypercalcemia. PTH and vitamin D regulation dominate. No clinical condition arises from either its deficiency or excess, e.g. from thyroidectomy or medullary cell carcinoma. Significance of calcitonin. Therefore, the physiological relevance of calcitonin is unclear. May be more important in regulating bone remodeling than in Ca2+ hemostasis. It may however be important in children and pregnant women, contribute to growth or preservation of the skeleton, used clinically or treatment of hypercalcemia, and in certain bone diseases in which sustained reduction of osteoclastic resorption is therapeutically advantageous. calcium-related pathologies. Hypocalcemia, common causes are vitamin D deficiency, chronic renal failure, pseudohypoparathyroidism, iatrogenic. Hypocalcemia, condition is associated with severe dietary restriction of calcium and is common in malnourished children in developing countries. Hypocalcemia, being increased response to hypocalcemia, reduced calcium, increased breakdown of bone, increased formation of calcitriol, and increased C absorption. So the increase in formation of calcitriol and increased C absorption occurs kidney. Increased formation of calcitriol acts on the gut, and eventually organ. What is osteomalgia? Osteomalgia is a disease which results from the failure caused by osteoid, resulting in demineralization of the surface of the bone. In adults, this results in partial fractures, explain bone pain, and a loose appearance on X-ray examination. In children, this leads to elongation and distortion in chondrocytes and the growth region of the cartilage. Bone growth, the epiphyseal plates, calcium and phosphate combine to produce a mineral called hydroxyapatite. Compact bone chondrocytes and cartilage. Causes of osteomalgia rickets: dietary vitamin D insufficiency, a lack of sufficient sunlight, dark skin pigmentation, pregnancy increases osteomalgia. Excess plasma calcium, commonly described kidney calcification, depression, and abdominal pain.